this. Now I invite Dr. Chandana to present a talk on nuclear imaging in dementia.
Is it possible to switch off that light? Thank you. Very good afternoon to everybody. At the outset, I thank Ratnavali ma'am, Pramod sir, and the entire team to invite me today, and also the various people involved in this dementia workshop. I have a question to ask before I start the talk. This is both to Ratnavali ma'am and Pramod sir. So do we have a role, if at all the biomarker of blood and CSF come? Do you think you would still send for PET imaging?
If we have availability of biomarkers, definitely the need for PET imaging would come down. That's what I think would happen in my practice. Right now, we have utilized PET to make a diagnosis in some patients, but that's because we didn't have another way of getting to the diagnosis. And since we know that the blood biomarkers and serum biomarkers have high specificity also, so I perceive a tilt towards more and more of biomarkers and less of PET scan.
PET scan. So, and sir, another question, what would be the cost if you had to do the panel of the biomarkers?
So in our setting, the CSF biomarkers costs around 17,000 rupees,
okay,
because that includes the lumbar puncture charges and the subsequent analysis. And the PET scan costs around 22,000 rupees.
Okay.
So right now the CSF biomarker is cheaper than the PET. When the blood biomarker comes, we're expecting it to be in the 7,000 to 10,000 range. So
okay,
that would be
much cheaper
as well.
Okay. Yeah, so I presume I won't have much role later. However, because just to say FDG PET, usually for dementia, we always suggest you combine with dopa PET, that is a dopaminergic agent, or a Trodat, which is a SPECT agent. So, because I work at St. John's, it is much subsidized. We charge about 18,000 for a combined dopa and an FDG PET. But in other private centers, it is difficult to do that. So, when it comes to amyloid PET, I think one scan would cost about 70 to 80,000. So I don't think so people would be able to afford it. And first of all, why pay so much just for diagnosis until unless the treatment really makes a lot of change. Anyways, I'll just try to impart whatever little I know about imaging in dementia, which is of course very fascinating. And before starting, I would say history is the main thing before anything, because only with the history we will be able to look at the imaging findings and come to some conclusion what it is, because PET is extremely sensitive, but it is not specific. So it will pick up everything, but you don't know what it is. Okay, so I start my talk today. So just a brief thing, we have something called SPECT, and which is a single photon emission tomography, which was used earlier, where perfusion tracer technetium ECD was used and dopaminergic tracer DAT was used. Okay, then came the PET, where you use the F18 based tracers. Some institutes are privileged to use C11 based tracers. So C11, PIB and all can be done, but you need to have an in-house cyclotron. So just to give a little bit of insight into why nuclear medicine is not taking up as well as in the West is the cost involved in setting up a cyclotron, getting a radiopharmaceutical lab is quite expensive. Until unless that infrastructure and the expertise are there to label it, it is difficult. But however, I think future is bright. I won't go much into detail. So we all know about PET-CT. PET-CT can do a great work. But yeah, I think what stands out in neurology is always a PET-MR. I think right now only 3 centers in this country have PET MR. One is Apollo Chennai, other one is at Nibhans, and then in Apollo Delhi. So these are the 3 places where PET MR is there. So before understanding the physiology, we should also know physiology, because brain is such a highly glucose, it takes up so much glucose for its metabolism. We need to understand the pattern, how the glucose metabolism varies according to the age. So when we are interpreting a scan, we need to know what is the basic thing that we are seeing at that particular age, and then do an interpretation. So I'm not going to go through, these are all in journals. So according to the age, there's different areas of decreased uptake which happen over time. Same thing with the sex. We heard a talk that certain dementias are more common in women and certain in men. Again, there is a difference in the way of pattern of metabolism in these brain structures too. So before going further, I would say we don't have an Indian population database. So I think the need of the hour, if at all we are going to use PET as one of the things for dementia, is we need to create an Indian population database, because the pattern of uptake can be very different from a Western population. So that should be the main thing if we are using PET for dementia evaluation. So as I said, the most common tracers are FDG PET and F18 DOPA and ECD and TRODAT. So this is again a tabular column which I want to say that many people, make a lot of hype, saying tau, amyloid imaging, tau and amyloid imaging. But we all know, I think if you see a lot of literature, I know it can be used for all the dementias. It comes in very early in that staging of picking up the biomarkers. However, it has been now approved only for Alzheimer's, not for other kind of dementias. So because there's a lot of, I'll go through the pitfalls where how imaging analysis is so important to make out whether the person is responding to a treatment, not responding to a treatment, and so many mixed patterns are there which is not very clear for us to understand whether it's a mixed dementia or purely Alzheimer's. So as Karthik already said, anatomy is extremely important before we look into the physiology of the brain. So the most important structures are all the lobes of the brain. Beyond that is the entorhinal cortex and also the cingulate gyrus. These are the 2 important things that we need to look into in analyzing any image of dementia. So many a times we get a lot of patients who come for dementia workup who are most likely diabetics, and they have a sugar level shooting up to 250, 300 and things like that. Just believe that if at all you want a good image of PET to tell you the clinical dilemma which you're having, the sugars have to be well in control. Ideally, it has to be less than 140 milligrams per deciliter, or maximum we can go up to is 200 milligrams per deciliter. If the patient preparation is not okay, then the scan will never be okay. So that is one very important thing in doing dementia imaging. And the second thing is, all these patients are kept in a dim lit room, because if you're kept in a very light room, the light itself can trigger a lot of uptake in the brain. So it is very important that the patient is, after injection, kept in a dim lit room. But whereas in diffuse Lewy body dementia, we ask them to keep their eyes open, because what we are looking at is the occipital lobe. So we are trying to say whether with the eyes being open, is the occipital lobe again having some increased metabolism or not. So these are the differences that you need to keep into consideration when you are doing an imaging for PET. So as you said, mainly anterior cingulate gyrus, posterior cingulate gyrus, look at the deep structures, the caudate, putamen and the thalamus, and definitely the other lobes of the brain. Most importantly, most of the metabolic signatures which can be picked up in a PET scan is mainly the cingulate gyrus and the precuneus. For any dementia reporting to be very accurate, you need to have a SPM analysis. So a lot of automated softwares are available which can do that. Again, having a normal database of Indian population becomes extremely important. So it does a lot of these steps automatically. So it is just a click of a button, but using the right software is also equally important. So at the end of it, you get a 3D SSP image, which is standard projection, which gives us the areas of hypometabolism and the hypermetabolism. Okay, I'm just coming to one case after the other. I won't go take much into the details because anatomy, physiology, pathophysiology, everything is covered. So the hallmark of this particular case is you can see that occipital lobe hypometabolism is there and posterior cingulate gyrus is lost. What is it? Precuneus is lost. Yeah, I heard it. Alzheimer's. So this is the SSP image which clearly shows the involvement of mainly the posterior parietal cortex along with the cingulate gyrus involvement. The entire precuneus is lost. Again, this is a little subtle. Definitely posterior parietal involvement, but it is asymmetric. Precuneus involvement. A part of occipital lobe involvement. So this is not a direct Alzheimer's. It is a parietal, I think Karthik mentioned that there is left-sided predominant and right-sided predominant. This is a left-sided predominant involvement of the parietal lobe, but however, though we see that in the PET, we find that the posterior cingulate gyrus was lost, here, if I see in the SSP images, it is not showing that significant. So whatever you see as blue is hypometabolism. So these are the patterns wherein, we become a little difficult to diagnose whether it is Alzheimer's because other signs are all saying it is Alzheimer's. So this is where the clinical history plays a lot of importance for us to know, to differentiate whether it is a mixed dementia or a pure Alzheimer's. Now this is another variant of Alzheimer's. Again, parietal atrophy, posterior cingulate very nicely involved, and the precuneus. So this is posterior cortical atrophy variant of Alzheimer's. Very significant hypometabolism of the frontal lobe and also the temporal lobe. So it is definitely, you cannot say it is a behavioral variant or a semantic variant. All I can say right now is it's a frontotemporal dementia. Now the further history will add on to which is the most prominent feature in this patient. Whereas in this patient who presented with prosopagnosia, you can see there is classical involvement of the right inferior temporal lobe. So this is semantic variant of dementia. In that, again, you have agrammatic or non-fluent dementia. So you have the classical involvement of these areas, wherein involvement of the Broca's area along with involvement of little bit of pre and post central gyrus. So your history and presentation will help you to pick up these metabolic patterns. Whereas in lopogenic primary progressive aphasia, look at the pattern of hypometabolism. Definitely the precuneus is not so much involved. Frontal and temporal is kind of preserved. So sometimes, it gives a very mixed pattern wherein you cannot come to a conclusion, but based on the history, you can pick up the metabolic signatures and come to a diagnosis. This is a classical, if you see all the scans had a occipital lobe hypermetabolism. In this scans, there is occipital lobe hypometabolism. There is preservation of uptake in the posterior cingulate gyrus, which is very classically called as cingulate island sign or the occipital tunnel sign. It is a diffuse Lewy body dementia. Another very difficult thing to pick up on a PET is a vascular dementia. So as Karthik mentioned, you have small vessel, large vessel and hemorrhage. So it is very difficult to pick up on a PET because we'll see some vague areas of hypermetabolism which does sometimes corresponds to the areas of the bleed or the infarct in the brain, but we'll not be able to give a conclusive diagnosis. So it is more of a diagnosis of exclusion where you look at the MRI, sees the areas of bleed and look at the pattern of hypermetabolism which is not fitting into AD, FTD or DLBD, then probably this could be vascular dementia. So coming to other atypical dementia, so not just looking at the cortical hypometabolism, you should also look at the subcortical regions. So most of the FTD patients will have a severe caudate hypometabolism. So that is also to be looked into in a PET scan. And always this has to be added on along with a DOPA scan because that gives us the DAT receptor binding in the basal ganglia. So this is how the normal basal ganglia would look. This is the Trodat scan. But whereas in other all atypical Parkinson's, you can have different variation of decrease in the posterior putamen. So we cannot make a diagnosis of which atypical PD it is we are dealing with unless we combine it with a FTG PET scan, because the pattern of hypometabolism in the cortex with the pattern of DAT receptor decrease in the basal ganglia gives us an idea of what kind of atypical PD we are dealing with. So according to the diagnosis of DLB consortium, they have said that we have to do an MIBG scan, but it is not routinely done because I-123 is not available in India. I-131 is available, and it is not routinely done because it is a laborious process wherein the patient has to be given something to block the thyroid. The patient has to come for 3 different days for the scan. So routinely it is not done, but for the sympathetic innervation of the cardiac, especially in multisystem atrophy, this is recommended in the guidelines. So these are the atypical presentations of dementia. If you see here, the pons is hypometabolic and the part of cerebellum is, but more likely, if you see the typical hummingbird sign, that is PSP. Again, in this patient, metabolic pattern is mainly involving the medial temporal lobe and a little bit of frontal. But if you see here, cerebellum is showing difference, is significant hypometabolism. So this is MSAC. This is a MND. That is, you can typically see a hypometabolism in the decrease in the pre and the post central gyrus. This is CBD affecting one side of the brain, and subsequent Doppler scan shows a decreased uptake in the basal ganglia. NPH can also cause decrease in metabolism in the brain, which can be more of global metabolism. So this will be how, this is actually CJD. As you said, a lot of MRI findings are there for the CJD, but if you see in PET scan, it has got cerebellar, that is hemicerebellar hypometabolism. That is the area of where you have this ribbon sign, that area is severely hypometabolic. So again, this I will not go into detail. So depending on the hippocampus and other areas, there are different variants of mixed dementias. Okay, just I'll run through this because I don't have a practical experience with this amyloid and TOF. But all I can say is fluorobetaper, flutometamol and 4-betapen are available in the, outside the country. In NIMANS, they are using F18 NAV as one of the tracers for the, basically for research setting. They have not started it clinical. Again, according to the Barak staging, there are specific guidelines to choose for amyloid PET. Protocol is good. You don't have to do fasting in amyloid PET. That is one good thing. But otherwise, the timing of imaging has to be properly timed. And only important thing is the way we see these images are all in the grayscale. We don't see it in the color scale as we see it in the FTG PET. And we see it from the cerebellum to above. Only flutometamol we see it in a color scale, and more so we look at the striatum. So these are the different patterns of normal uptake in an amyloid PET, and what you see here is the abnormal deposition of amyloid. So white matter is seen in a normal. If you see the grain matter, it is the abnormal. Yeah, these are all some of the pitfalls where a lot of atrophy can give us a impression that it is not affected, but because it is of the severe atrophy, the pickup is not there on the scan. And this is a difference between amyloid and TOF. And this is a case report from Dr. Madhavi Tripathi from AIMS, where they have done F18 TOF. So if you see here, posterior cortical atrophy, you can see that there's a decrease in uptake in FTG PET, but the same area is showing increased uptake in TOF. This I will skip. Anyway, one of the things we have to keep in mind with amyloid therapy is other changes of edema and hemorrhage, which can give a different pattern of pattern of uptake, and MRI has to be correlated to differentiate the both, and some mimics as CAA and hypertensive bleeds to be kept in consideration. So to rule out, always do amyloid PET. To rule in, do a TOF PET, and for differential diagnosis, do an FTG PET. As a take-home message, I say, for the initial diagnosis, still FTG PET is good until unless we have amyloid and people can afford it. Thank you so much. And this is my team at St. John's. Thank you so much.
And you have any comments on that?
ASL is, nowadays included as part of it, and it kind of mirrors the PET in many of the findings, except for a few artifact proneness, if there's a stenosis in the carotid, which happens in these elderly population. Otherwise, it mirrors the PET findings. Yeah, certainly.
Multiple articles are published comparing ASL with FTG PET.
Thank you, Dr. Chandana, for your insights. We'll now take one more question because we are really running short of time. Any questions?
In my hometown, PET is not readily available, but MRI is available anyway. So my impression may be biased, but oftentimes PET seems to give direct, visually confirming diagnosis, whereas the MR-based impressions are maybe possible like that. Does that hold true, or is my own personal bias?
No, sir. That's what I said. If you're using the imaging software, then you can be sure about what you're reporting, because it is a statistical analysis of the uptake in the brain. So you can be sure. So if a PET nuclear medicine physician is giving a categorical this thing, but it has to be correlated with the history and not just on the image. But you can go with it, sir.
Sure.
Just
Please,
really,
Dr. James.
Yeah, so I want to just interrupt. I want to add a comment to this. It's a great discussion. I think the best imaging modality is the one you're familiar with using and the one you've got access to. Okay, that's number one. If you had the choice, in my experience, but in several countries, but European countries, it's really unusual for an FDG PET to show something that's not visible on the MR focal atrophy, including the examples you gave here. Now, it's sometimes easier to see with PET because it lights up big and bright, but actually the abnormality is always there, focal atrophy, sulcal widening. But not every person can have an MR, not every centre has access to MR or indeed to PET. My own view would be, if you've got access to MR and the patient is tolerating MR, I would go for an MR because you'll see all the localised deficits you see on PET, plus excluding other pathologies. But that's not fit for every patient. And there is, I think, there's still an important role for PET, particularly where the MR is equivocal. That'd be how I would. Thank you.
Thank you, Dr. James.